So this session is interactive and mainly aimed at FRCPath Part 2 exam, and it will help in daily life as well, but we aim at FRCPath exam. So I would need some volunteers to answer the question and report the blood films just as it is asked in the FRCPath exam. So this is the first case. A 33-year-old man came to A&E with persistent headache. He was referred by his GP because of the headache. And in the A&E, it was found that his blood pressure is 210 by 130. The full blood count shows hemoglobin of 110, white cell count of 11, platelet count of 210. He is an AKI1 with mild raised ALT. The BMS called you because he has seen some um, abnormal cells in the blood film, and now you are the hematology registrar, and the film is with you. I need a volunteer to comment on this blood film and then report the blood film, please. Fatima, can I request you?
Yeah, I think I will start by checking the cell power. Um
Okay, so I will go to power 10.
just to check with this scenario, I will try to. I don't think from this power I'll be able to see platelets, but I will try
Hmm.
to identify if there is any apparent um, thrombocytopenia or RBC's fragments. Then I will
Okay,
go in to comment.
yes. So
Yeah, I
you have seen here a fragment which is here.
yeah,
Reticulocyte is here. This patient has a lot of neutrophils, maybe an element of infection.
yes,
Platelet looks high. They are quite a lot in this field only. And fragment, fragment, quite a lot of fragment here.
yes,
Okay, so you have seen a hemolytic picture here because there are reticulocytes, there are fragments, and you have seen NRBC as well.
yes, yeah.
Yeah, so what name would you give to this picture?
I will say
If
it's
the,
suggestive of macroangiopathic MAHA.
the
MAHA.
MAHA is there.
Yeah.
Okay, right. So what is the likely cause of MAHA here? Do you have any differential diagnosis in your mind?
When I think when we speak about MAHA, first I will put TTP, HUS.
Okay.
How old is the patient? Sorry, I missed that.
The patient is 33-year-old.
Okay. So yeah, I think TTP, HUS, especially with this renal impairment.
Mm-hmm.
Um, I'll consider that on top of my differential. Um, Platelets count is normal though, or looks adequate on this blood film.
Mm-hmm. Right. Is there any information in the history that is helping you or not? The blood pressure of the patient was 210 and 130.
Oh yes, yeah, hypertensive. If she was a female, if she's pregnant or not, then I will consider pregnancy-related causes.
Yeah. He is a male.
He's a male, okay.
Yeah.
So it could
Right.
be hypertensive crisis or
Yes. Malignant hypertension can also lead to MAHA picture as well.
yes.
So in the exam, you would be asked, report the blood film. How would you report this blood film?
So I think I will comment this blood film is showing numerous RBCs fragments, more than five fragments per high power field, um, showing also NRBCs and polychromasia. I will also comment that the platelets are adequate and white cells showing neutrophils with toxic granulation. Uh, so I will urgently contact the medical team and
So, so you have now completed a segment of the report that the blood film shows RBC fragments, NRBCs, polychromasia with normal platelet count and increased uh, neutrophil with toxic granulation. Now,
mm,
the second part is the blood film is consistent with most likely
blood film is most likely consistent with MAHA picture or microantipathetic hemolytic picture.
Ma- MAHA picture. So you have completed two parts now out of three. Now you will suggest what to do next.
Mm,
This patient needs further investigation, for example, or
yeah,
need other assessment.
yeah. So I would comment that this patient needs urgent assessment with with full history and examination and checking kidney functions, checking UNEs, LFTs, and
Okay.
uh, yeah.
So you will mention that the patient needs further investigations to rule out different causes of MAHA, like sepsis. This patient has increased neutrophil count, so the patient would need cultures. You will not mention cultures anything,
Mm,
but you will say workup to rule out sepsis as a cause of MAHA, hemolytic uremic syndrome, drugs, malignancies, and etc. So you have mentioned three or four causes of MAHA. So
okay.
then your report is complete. Sometime the blood film is from the GP. Then you have to address the GP in your blood film. That this patient need in further investigation or referral to hematology, or this is an emergency, need to be transferred to hematology as soon as possible. So depending on the scenario, whether the patient is in the hospital or the blood film is from the GP, you have to address accordingly in the exam.
Okay.
Now, the second question in the exam would be, what are the differential diagnoses of MAHA or TMA?
Yeah, I think we will go through them again. So, TTP, hemolytic uremic syndrome, um, atypical hemolytic uremic syndrome, um, hypertension, malignant hypertension, um, pregnancy-related causes. Yeah, is a male. Um,
Okay. Do you have a transplant unit in your hospital?
Yes. Yeah.
Yeah. So, which drug is most likely responsible for MAHA picture in transplant patient?
I think it's tacrolimus, isn't it?
Yeah. So, tacrolimus is more. Cyclosporine is also involved in causing MAHA as well. So, in practice, we see a lot of MAHA picture in transplant patient and in renal patient as well because they use a lot of cyclosporine and tacrolimus. And TTP is both. It can be acquired and congenital. Keep in mind this fact. And um, infections as well, sepsis. Usually, a patient in DIC, you would see a lot of fragments in their blood film. And mechanical, the heart valves, old heart valves, which is now dysfunctional, you would see anemia in that patient and fragments. Rest, white cell count will be normal, platelets will be normal, LFT, ALT, everything will be normal. So mechanical hemolysis or from the cardiac well, you can also see um, MAHA picture.
Okay.
Then the last question would be, what is the immediate management of this particular patient?
So the immediate management, this patient needs to be admitted to the hospital if he's in the community. Uh, we need to control his blood pressure because um, if that's the cause, that needs urgently to be dealt with. Um, he may also need escalation of care to ICU or HDU unit for that.
Yeah, so the patient need a specialty involvement, like renal team to control his blood pressure urgently, and then repeating of the bloods to see with correcting blood pressure, the blood print and the blood tests have improved or not. So then your short case of morphology will be completed. MAHA is a must question in the FRCPath Part 2 exam. It will come either in the form of a TTP or in the form of a cardiac valve or in the form of hypertensive emergency or malignant hypertension. But it will come must.
Mm,
And if you do not see any blood film in morphology paper, you will see a TTP question in the coagulation paper then.
okay.
Because this time we do not have any MAHA blood film in the morphology section, but we have a full question on TTP. So uh, you cannot avoid MAHA for the FRCPath Part 2 exam. All right.
Hi, thank you very much.
Thank you. Okay. Now the second case. This patient is a 45-year-old female referred to hematology department because of uh, weight loss, um, decreased appetite, and abdominal mass on palpation. She is progressively getting anemic as well, and the GP is worried that she may have any hematological malignancy. So when you examine the patient, she has a large abdominal mass in the um, left on the left side of the body, abdomen, and there are many lymph nodes in the axilla and in the neck area and in the inguinal area. The blood film shows some abnormal cells, and the biomedical scientist is worried that what can this be? The hemoglobin is 110, white cell count is 15, and platelet count is 110. So I need a volunteer to comment on this blood film. Anyone want to go on this blood film?
So yeah, if we look at this blood film, here we can see evidence of mild to moderate leukocytosis with some lymphoplasmacytic lymphoplasmacytoid lymphocytes.
Yeah, so this is power 10. I will go to power 50 and you can see better.
So
So, yes.
so can see here population of mononuclear cells with um with irregular nucleus, dense chromatin, vacuolated cytoplasm. One of them is showing the flower shape appearance, I think.
Sorry, can you repeat which shape?
The one at around 6 o'clock here is showing the flower shape appearance.
You mean this one?
This one, yeah. I don't know, irregular nuclear shape. I think I can say that.
I will make show it by you by 100 power. This one. This is a bit flowery shape.
Yeah, this one is, I think.
What about these cells?
So,
I will focus it for you. This one.
yeah, so this is mononuclear cells with increased NC ratio,
Mm-hmm.
um, dense nuclear chromatin. I don't think I can identify nucleolus here. Cytoplasm, bluish cytoplasm with some vacuolations. Um, I think I can call it blast.
Okay. Yes, this is a blast. I will show you some more of them.
Yeah, again, this is the flower shape
Flowery.
appearance. Yeah.
We'll go back to 50. about this cell? They are quite large, right?
Yeah, they're quite large. Yeah, increase NC ratio.
This one, they're quite large as well.
Mm.
So these cells have vacuolation as well, basophilic cytoplasm, large cell. So what do you think are the possibilities here?
Yeah, because of the flowery shaped cells, I was thinking about T cell lymphomas, but with the bluish maculated cytoplasm.
So what is your differential diagnosis here?
Um, I would think about leukemic phase of or
Leukemic phase of
leukemic transformation of lymphoma.
uh, which lymphoma?
T cell lymphoma because of the background flowery shaped cells.
Oh. So this patient has no background history, and she presented to you first time with large abdominal mass and l- lymphadenopathy everywhere,
Yeah,
cervical area, axillary, inguinal area with B symptoms. And you have seen these large cells with basophilic cytoplasm and vacuolation.
yeah. I think Perkins should also be on the top of the differentials because of
Yeah.
these speculations in the cytoplasm plus blast.
Yes. So if like many things can cause vacuolation in the lymphoid blast on the blood film, you may see vacuolation in the Burkitt lymphoma, in ALL sometime there are vacuolation as well, and in diffuse large B cell lymphoma.
Mm.
The Burkitt cells, they are very basophilic. They are more basophilic than this cytoplasm, and all of their cells have vacuolation. And the presentation of the patient uh, is usually different in Burkitt. Burkitt have one mass in the body area. They do not give you a disseminated lymphadenopathy usually. Whenever there is a presentation of Burkitt lymphoma, you will see a mass at a local area, and that's it. This patient has widespread lymphadenopathy. Some of the cells have vacuolation, some do not have vacuolation. Very large cells, you can compare the size with the RBC. Some of them are vacuolated, other are not. so you so so you will report the blood film as the blood film shows large atypical white cells, most likely lymphoid, with um, vacuolation in some of the cells. The red cells are okay. Or if you have noticed any NRBC, you can mention NRBC are there as well. The platelet count is decreased, no platelet count. The film is most likely consistent with high-grade lymphoma because you see this type of large cells in high-grade diseases, the Burkitt lymphoma, DLBCL only. The follicular, mental, CLL, marginal zone, they have small to medium lymphocytes, but the Burkitt and the DLBCL, they have um, large cells. So you would say suspected high-grade lymphoma or lymphoproliferative disease. This patient need uh, to be admitted under hematology urgently. We need further investigations like blood flow cytometry in this patient and um scans of this patient. CT cap we do usually to find out the extent of lymphadenopathy and to stage the patient. After that is the PET scan. So you cannot make a diagnosis here. And what is the diagnosis here? But you give your suspicion that this is a high grade lymphoproliferative disease or lymphoma. You will confirm your diagnosis by requesting further investigations. So, what will be the further investigations that you would like to do in this patient to confirm the diagnosis?
So I think I'll first mention routine investigations, UNEs, LFTs, LDH, profile, PLS markers. Then I'll mention imaging, the CT CAP, and then I'll mention histological diagnosis like a biopsy from the lymph nodes.
Yes. So, first important thing is the flow cytometry. You need to send to the lab, confirm your diagnosis, whether it is high grade or low grade, and then um, the imaging would tell you whether there is any lymph node that you can biopsy or not. If lymph node cannot be biopsied, then it's the bone marrow biopsy. But this patient has large abdominal mass, so which is easy to biopsy. Um, so you will mention biopsying of the lymph node. Okay. So the flow cytometry result of this patient is um, CD5 negative, CD10 positive, CD19 positive, and 20 positive.
This is consists like this B cell.
Do you think this is large B cell lymphoma?
Yes, it could be the DLBCL because of TD10 positive and B markers are positive, CD5.
Uh, right. But if they have given you some other information, like if they say that this patient is MYC positive, MYC positive, TP53 positive on molecular studies, then how would you refine your diagnosis?
If c-MYC positive, TB53, not quite sure about the TB53, but if c-MYC positive and Chi67 is more than 98%, then Perkins will be the
I mean,
diagnosis here. Mm.
I mean to say whether you will mention double hit lymphoma or triple hit DLBCL or not, because this will complete your answer if they have given MYC, if they have given you BCL2 or TP53, um, then you have to mention whether this is double hit or triple hit uh, DLBCL or large B cell lymphoma. Right. So this patient is 45-year-old female and stage 4 disease with large abdominal mass and persistent B symptoms, decreased appetite. What is the prognostic score that you would use here?
IPI score.
IPI. score. Okay. So, for example, IPI score of this patient is 3. Do you have any options of treatment for this patient or not?
I think polar R chip will be the preferred option here.
Okay, yeah. So if you mention in the exam that because of high IPI, I will offer uh, the patient Polar trial or uh, Polar R-CHP 6 cycles, that is enough because they want to know which chemotherapy you will offer to the patient. The new guideline for DLBCL has algorithms for patients less than 80, more than 80, and stage 1 or 2, stage or high stage RPI less than 2 or more than 2. Better to memorize them because they can ask about the options of chemotherapy. We have R-CHOP, we have polar R-CHOP now, and in young fit patient with no comorbidities and high IPI, you can offer them Orthodox M or RI-VEC as well. Right. Can you offer them CAR-T?
If they are refractory in the first year of treatment, isn't it?
Yes. So CAR-T is a second line in DLBCL. Um, in other cases, like in mental cells, they are third line. But in DLBCL, you can offer them um, CAR-T if they are refractory or relapse within 1 year. Do you know the name of the CAR-T cells that we use in the DLBCL? XC cell. Right. And the last question, do you know any new treatment for DLBCL as a third line? You may be using glofitamab in your hospital or loncastuximab in your hospital. Epcoritamab is also uh, approved now for DLBCL. So I asked more than usual question in this scenario because DLBCL is a hot topic in FRCPath Viva. So if they asked you regarding DLBCL, they will give you a scenario, go through the flow cytometry, investigation to confirm the diagnosis, double hit and triple hit lymphoma, IPI score. They will tell you that this is the LDH, this is the age of the patient, and this is the stage of the disease, what is the likely IPI of the patient, and then uh, pre-chemo test, patient consent, this patient is 45, pregnancy test as well, and then choice of first line therapy in this patient. What if this patient relapse? What is the second line options? Do you have CAR-T or auto transplant? And what is the third line option in the patient? Now we have many bispecifics and loncastuximab, epcoritamab, and the glofitamab, and the bispecific side effect, the CRS. They can ask you about this as well. So DLBCL is a favorite question for Viva.
So when it comes to the diagnosis, just to clarify that point, I don't need to say specific diagnosis, do I? Is it just to
No,
say suggestive of high grade lymphoma?
in the blood film, you cannot diagnose that this is Burkitt lymphoma or this is DLBCL or this is CLL or mental cell, etc. You always need supportive diagnosis that we do in our routine practice. When we see such blood film, we send the blood to HMDS as soon as possible and get the provisional flow within an hour to see which side we are heading, whether this is high-grade lymphoma, if yes, it is a Burkitt or it is a um, DLBCL. This is a routine practice that we do in our hospitals. We cannot diagnose anything on the blood film. You always need flow cytometry, cytogenetics, and this stuff to confirm that your diagnosis.
Yeah.
You, even even for CLL, you need flow cytometry to differentiate it from mantle cell lymphoma because mantle cell lymphoma has five different variants. It can be a small cell variant, it can be a marginal type of mantle cell lymphoma, it can be pleomorphic lymphoma, it can be a blastic mantle cell lymphoma, which present like ALL.
Yes. Right.
So, so always you have to say in your paper, the morphology paper, that most likely consistent with this diagnosis, but you need certain tests to confirm the diagnosis. And you will mention flow cytometry, bone marrow biopsy with cytogenetics or molecular studies, or lymph node biopsy if I'm unable to biopsy on the imaging. Now the third case. Yeah, so this is the trephine of a 50-year-old patient uh, who has persistent low back pain and abdominal discomfort. Uh, the blood film shows pancytopenic picture. Because of pancytopenia, you did the bone marrow biopsy for this patient, and this is the gym sustain with um, power 4. So I need someone to comment on this refine.
Okay,
Anyone?
good.
Okay. Yes.
I can call.
Yes. So this is the power 4. I can go here and there slowly, and then I will move to power 10. And this is the gem sustain.
Okay.
Okay. I will go to power 10. Right. Do you have any thoughts about that?
Well, as far as on low power, I can comment on the adjacent thing to find biopsy as I can see 3 to 5 intertemporal areas. And while its trabecules are slightly thickened. Uh,
Sorry, which area is thickened?
adjacent length to find biopsy, but bony trabecules is I am saying that slightly thickened. Can you hear my voice?
Um, Sorry, I cannot hear you clearly.
Okay.
This is the,
Now,
yes, somewhat better. This is the peritrabecular area. This is the power 50.
okay.
The in between the spaces, the cells are somewhat normal, but near the peritrabecular area, they are they are having a distinct structure.
Yes, it's altered background structure. So
What are
slightly,
these cells?
these are like fibroblast and slipper-shaped cells, but I cannot see or focus the individual cells.
It will be very difficult to focus on an individual cell in Refine because they're very small.
Yeah, these
Uh,
cells are having, most few cells having the eccentric nucleus and with slightly pinkish cytoplasm.
hmm.
I think these are plasmacytoid cells, which are prominent.
So you have low back pain, you have pancytopenia, organomegalies, and you have a gem sustain Refine in the exam.
Hmm. So few lymphoid cells are also present here,
These cells,
and
these are the diagnostic cells, the spindle shaped cell.
these are spindle slipper-like cells, and maybe non-hemophagocytic cells or
So spindle shaped cell is the feature of
mastocytes.
spindle shaped cells are mastocytes. And the
Hmm.
characteristic feature on the Refine is peritrabecular fibrosis.
Hmm.
And they are best seen on gem sustain. So you can see the body is fine, but peritrabecular area is all like fibrotic. This,
Hmm.
yeah. So this is the feature of um, systemic mastocytosis.
Okay.
Yeah. So remember this point. If you see peritrabecular fibrosis, think about mastocytes. And the mastocytes are spindle-shaped cells which are very well pictured here on high power.
Okay.
Yes. So now, how would you report this trephine?
So adequate length to find biopsy and slightly thickened bony trabeculae and cellular for the age, slightly higher cellular for age. And I can see the altered background fibrosis, as the fibrosis is prominent in the peritrabecular areas. And these spindle cells are also, there is a spindle cells are also prominent in the peritrabecular areas, and slightly tri-lineage hematophysis is active, and trabeculae are also thickened.
Yes. Most likely consistent with
Consistent with any infiltration of mast cells.
mastocytosis, most
Mastocyte.
likely consistent with mastocytosis, but you have a criteria to diagnose systemic mastocytosis. Do you know the major and minor criteria of systemic mastocytosis?
Uh, but on biopsy, I think I'm not remember. I haven't remember, but maybe more than 30% mast cells in biopsy in major criteria. I don't remember.
So in major criteria, you need an aggregate of more than 15 mast cell in the marrow or in any other organ in which you are suspecting mastocytosis. And for minor criteria, you need more than 25% spindle-shaped mast cell. Number one. Number two is the KIT mutation.
c-KIT
Number
mutation.
three, number three is certain flow cytometry markers like CD2, 25, and CD30.
Mm.
And the last one is serum tryptase more than 20 nanogram per ml.
Mm.
So you need one major or one minor criteria to diagnose systemic mastocytosis, or three minor criteria to diagnose it as systemic mastocytosis.
Okay.
Yeah. So you need to do flow cytometry on this patient. You need to send serum tryptase level on this patient, and molecular would be done on this bone marrow biopsy for c-KIT mutation to find out if this is um, systemic mastocytosis or not. So peritrabecular fibrosis, GIMSA stain, because GIMSA um, is the best stain to find out mastocytes. Uh,
Mm.
bony lesions or bony pain of the patient, pancytopenia. These are all the hints that is given to you in the exam to diagnose systemic mastocytosis.
Okay.
How do you treat systemic mastocytosis?
By means of supportive treatment and chemotherapy, targeted therapy.
Do you do you know any
It,
chemotherapy drug?
it depends upon the molecular abnormalities. Metastatin can be used. c-KIT, TKI inhibitors. It depends upon the molecular abnormality,
No.
what underlying cause.
So you can use KIT inhibitor TKIs can be used, but if there is KIT inhibitor and PDGFRA mutation as well is there, then we have a new medication these days, avapritinib, which is a bit new in systemic mastocytosis. There are
Abdutinib?
many. Yes, sorry.
Oh, are you saying abdutinib can be used in IPDGFRA?
Avapritinib.
Ever. Okay.
Avapritinib. This is a new drug, avapritinib, and there are many trials going on in systemic mastocytosis. So, if asked in viva, you should remember their name and the drug name um, for good mark.
Okay.
One of the drug is called bezuclastinib. It is under trial, and another one is ilinistinib, still in trial. But avapritinib has been approved, and we are using it in our patient.
Okay.
Right. So the second last case. So this is a 30, 33-year-old female referred from a district general hospital to you with a suspicion of leukemia. The full blood count shows hemoglobin of 131, platelet count of 150, and white cell count of 420. This is the blood film. So I need a volunteer to comment on the blood film. Anyone? Sana Ajmal.
Assalamu alaikum.
Wow, salam. Yeah, so this is the power 10
Yeah.
of the patient, and you can see it is full of cell.
Mm.
All right, I will go to power 50.
Mm.
I think this
Yeah.
picture has all the cells that you need to know for the
Yeah.
diagnosis.
So there are the marked neutrophilia, like myeloid proliferation with all the stages, like promyelocytes, and there is this one is the basophil as well with the neutro, and this one on the right side, yeah, this one. So is there the different stages of myeloid maturation, like uh, promyelocytes and the myelocytes and neutrophils. There's a lot of neutrophils more than other. So so in this age, in this lady uh, with the basophilia, it's a periphery, I think. Is it? Is the peripheral
Mhm.
film? Yeah. So it's looks like a CML. but it could be in the differential with the CMLN with the neutrophilia, but it could be, but with the P230. Uh, but my initial provisional should be the CML for that patient, chronic myeloid leukemia.
The blast are 21%.
So it could be in the blast phase then. Uh,
So you cannot say that this is
mm,
CML straight away on the blood film.
okay.
Uh, you need blast percentage, you need BCR ABL
Mm,
translocation, and then
okay.
uh, uh, you can comment whether this is CML or
CML.
CML in the blast phase.
Okay. Because in Pakistan, when we used to do the morpho, normally go for the peripheral film for the CML patient, and just, yeah, there's the myeloid hyperplasia and the age favor that, and there's the basophilia as well. So not very advanced techniques, but we were our provenal could be with the CML for that.
Yeah, so most likely consistent with chronic myeloid leukemia, but you need
Mm,
uh,
yeah, for
further
the
test
BCR.
further
Yeah,
test to exclude blast phase or AML, because
yeah.
if a CML patient with blast more than 20% is AML, according to WHO 2022,
Okay,
right?
okay.
Is there any other category where a 20% blast cutoff is required to diagnose it
I
as AML?
I think there are the three, except the three like core binding factors for leukemias and in translocation 16, 16 and inversion 16, except that all need the 20% according to the new WHO classification. They doesn't require the 20% criteria for that. All
MDS.
other than, yeah, sorry.
MDS all if MDS convert to the acute myeloid leukemia, then require the more than 20% blast. CMM will also require more than 20% blast.
Now, in acute myeloid leukemia, all categories, if you have the specific mutations over there,
It
um,
821 and translocation 16, 16. I think uh, these doesn't need the 20%. I think if I'm not wrong, and I'm not saying the reverse.
so WHO 2022 has mentioned two categories: AML with defining genetic mutation and AML defined by differentiation. So all these mutations come in defining category where there is PML Aurora, RNX1, BCR-ABL1, KMT2A, MECOM,
Oh yeah,
DUPNUC, NPM1, etc. If any of these mutations are present, they are called as AML
yeah.
um,
Without 20%,
without looking at the blast count, except BCR-ABL and CEPA, CEBPA. They need more than 20% blast to call it as AML. So
SEPA
only
and
two, yeah. So there are two defining mutations in AML which need to have more than 20% blast, consider it as AML.
so in
But if
that case, as here if the BCR ABL1 positive, then we should need 20% criteria for that to diagnose to label it as the EML.
yes, if this
Mm.
person has 8% blast
Mm.
in reality, but if she had 21% blast, then I would treat it as AML.
Okay. Okay. Okay, I got you. Thank you.
Okay, all right. So now you have done the BCR-ABL1 for this patient, which is positive, blast are 8%, and this patient is diagnosed as chronic myeloid leukemia in chronic phase, not in blast phase.
Chronic phase, yeah.
Yes, okay. So, how would you explain to the patient that you have chronic myeloid leukemia and CP, and how would you explain the management?
In that patient, I will explain that it's a leukemia of blood, and although my clinical is not that much good in preference of some like counseling or just uh, to tell the patient about the diagnosis, but I will tell him about his proper diagnosis uh, uh, and we will start from the imatinib and for that TKIs. I will offer the TKI for that, and I will tell him about tell her about the response that we will check for that patient uh, in a year at 3 months, 6 months, and 12 months for that patient. And I will explain about that it will be the treatment for a year, and we will check the response, and then for at least we will continue this patient until the patient is not going into the complete remission for that. And we will go for the monitoring of that patient on the basis of molecular and the cytogenetics. And then I will go for the drug details and its side effect for that patient. So I will start that there could be this different side effect of the TKIs, major grade, minor grade, late effects of all the disease, all the drugs.
So,
So,
explaining diagnosis and prognosis to a patient was a question this time in FRCPath exam.
okay.
The patient had a diagnosis of APML, and we were asked to mention uh, prognosis, treatment options, complication of the treatment and diagnosis to the
Oh,
patient. It was in the morphology paper, right?
okay.
You
Okay.
can expect any question in the exam, and these things we do routinely in our daily life. Whenever we have a diagnosis, we ask our staff, the CNS with us or ward staff, to come with us, and we carry with ourselves the leaflet of the disease and the possible treatment option with us,
Mm,
and ask the patient that we have the results of your disease. Do you want us to explain it to you now, or you need some family member to be
okay.
present in the room or not?
Okay. So is
And
there protocol or guidelines for that? Because we are basically from the diagnostic part, and we really don't know about all these counseling, and because we don't have interaction with the patient. So is
so,
there protocols or any guidelines for that you um, for,
no, if you are appearing in FRCPath Part 2 exam, you are
mm,
appear you are becoming a consultant.
mm,
And once you become a consultant, ST6 or ST7 registrar act as a consultant here, and
okay.
the expectation is quite a lot from the registrar ST6, ST7. When you have a diagnosis like this, you need to explain to the patient what is the next step you would like to do, what are the treatment options, whether the patient is fit for the treatment or not.
Mm,
All this have to be done by you. No one else would do that for you. Um, so in terms of this patient is 33-year-old. Pregnancy consideration is very much
mm,
important. And then uh, prognostic score you have to apply here. ELTS or so-called score. So-called score is old now, but we
Mm.
apply ELTS score, which include blast percentage, age, splenomegaly, and one more uh, to find out whether the patient is high risk or low risk. Then you have explained to the patient the diagnosis that you have the leukemia of the white blood cell, but it is in mild to moderate stage and
Mm.
not in aggressive stage. So you do not need
Mm.
intensive chemotherapy at the moment. You are fit for the tablet form of therapy to control your cell count. But we need to do some investigations on you to find out uh, whether you are fit for chemotherapy or not. The first step is the pregnancy step because she is a young female. Because if she is pregnant, you have to be careful with TKI. And you have the option of interferon.
Okay.
Then second thing is that you want to do the bone marrow biopsy on the patient to find out whether this patient has major root abnormalities or not.
Okay.
Do you know major root abnormalities?
Yeah. Other than the these are the like uh, other abnormalities like trisomy 8 or trisomy 19 or is there any other complex karyotype that
Yes. Extra
need
pH and isochromosome 17.
yeah extra
Yeah.
chromosome.
For the presence of these major root abnormalities
Yeah.
means poor prognosis.
Yeah.
And then patient examination for any edema, any lung abnormalities like pleural effusion infection, cardiomyopathies by echo, ECG, chest X-ray, baseline HbA1c, which is called Q risk scoring. You have to do as a baseline in these patients.
Okay.
And then if this patient has high ELTS or so-called score, or if this patient wish to have kids in the future and want a rapid molecular response to achieve, then you can start from second generation TKI, dasatinib, not from first generation imatinib, um, because there are
Yeah.
few indications of second generation TKI where you can start them as a first line. If the ELTS score is high, if the patient is young, fit, and wish to have pregnancies in the future, the female patient, and if you want to bring patient quickly in remission, in case your transplant team is thinking about transplanting due to the presence of major root abnormalities, then you can offer them second generation TKI, dasatinib.
Dasatinib. Yeah.
Mhm. Then there are three or four TKIs that you can use first line. You should remember their contraindication and side effects.
Mm.
Dasatinib desaturate the person by
Yeah.
causing
But
pleural effusion and cardiomyopathy. Nilotinib um, has contraindication of neurovascular symptoms,
uh,
um, stroke, and cardiovascular. Imatinib has least side effect and contraindication,
mm.
and so remember this stuff. um, in the exam, CML has appeared twice in the Viva in a row. The
Okay.
last FRCPath exam and the one before that had a CML question in a young lady, and they asked us about differential diagnosis, um, prognostic scores,
Mm.
pre-chemo testing, first line drugs, second line drug, third line drug, SMNib, and uh, treatment-free remission, TFR as well.
Yeah.
So these are the favorite questions of the exam.
It's been always complicated to decide for what should be for the patient is the first line, second line, and the third line. It's all depend on the contraindication and the side effect and the patient suitability for that drug.
Yes, and the ELTS score. If it is a high risk ELTS score, then
Hmm.
you start from second generation. If it is a low risk ELTS score, then you consider first line as imatinib is the best one.
Okay. Because there was very confusing table, I think, in the ELN for the suitability for the first line and the second line drug, and there was lots of side effect and the contraindication, and they decide for which drug. It's been always confusing for me to decide for any patient to go for which drug exactly for that patient.
So the BSH says goes
Mm.
according to the ELTS scoring
Okay.
and patient condition.
Patient condition and their
Mm.
comorbidities.
Yes, but if someone has past history of um, cardiomyopathy, you
Mm.
cannot give them dasatinib. If someone has past history of stroke, then you cannot give them nilotinib.
Yeah. Okay.
So the last question,
Dr. Rama, I have a question. You said they also asked you about the differential diagnosis. So, uh, my first question is, when you report this case, you will write that there is a myeloid hyperplasia and your findings are consistent. Will you say that your findings are consistent with chronic myeloid leukemia and you want to confirm it with either with FISH or BCR ABL?
yes, so you will say consistent with most likely chronic leukemia, but I would like to confirm it with um, further testing, flow, fish, PCR, because if the blast percentage is more than 20%, then this is AML.
No,
Mm.
if even on peripheral film you think that the blast percentage is not more than 20% and they are less than that, still you will go for the flow cytometry.
Yes, for confirmation, you have to do that, but you do not have this much time in the exam to count the blast percentage, because
Okay,
blast
and
percentage
Uh,
takes time. Mm.
Dr. Amar, can I add one thing here?
mhm.
Yes, go ahead, please.
Yeah, according to the new WHO guideline, if there is less percentage of blast, even they are less than 20% of blast in case of CML, and the peripheral blood picture is suggestive of the chronic myeloid leukemia, and you have the less than 20% blast, and these blasts on flow cytometry are the bona fide of lymphoblast, then whatever the blast percentage, it is treated like is a acute lymphoblastic leukemia. What are you saying about this?
Never
Because
heard
the
about that. Um,
because
we
accelerated phase of CML is now excluded, and
yes,
there is
we
a
have only chronic and blast phase, but one which you are talking about treating as ALL. Never heard about that.
because accelerated phase has been excluded in new guideline, and now
Yes,
this is a chronic phase with disease progression. So whenever there is a less more than 10% blast, and you are seeing in the blood film, and you have the suspicious of CML, and these blasts are consistent with the lymphoblast, then whatever the percentage of blast, you having the most strongly suspicious of lymphoblastic leukemia. So you can label it as a blast crisis of lymphoblastic phase. So
yes.
I don't know. I just read about it, and so I have confusion about it.
So blast crisis or AML, almost the same thing. You give them
ALL.
intensive. You yes, you give them intensive chemotherapy. If you see the CML guidelines of the BSH, they have mentioned algorithm for myeloid blast crisis or lymphoid blast crisis, and both of them have been treated with intensive chemotherapy as the acute leukemia.
No, I'm not talking about the treatment options of flow chart. I am talking about the diagnosis.
So you mentioned you will treat it as ALL. How? Like ALL has a separate flow cytometry markers and genetic mutations, and CML has a separate flow cytometry markers, and one is myeloid, one is lymphoid. You can send me the question. I will go through it, and
Okay.
then I will answer accordingly.
Okay.
Will kindly tell the differential diagnosis of CML?
So it can be um, this one, what is called leukomoid reaction. It can be a leukomoid reaction. It can be an AML. It can be a CML. It can be a CNL as well. So you give 3 or 4 differential, that is fine.
Yeah, but that depends. CNL, but it will depend upon the age of the patient. We can't say CNL in a young patient. And when
Yes,
we,
that's why it is one of the differential, and you will exclude it on this basis that there is a myeloid peak in this film. Uh, Also, neutrophil count is high, but they are not mature. And in leukomoid reactions, although the white cell count is high, but there should be no basophil in the leukomoid reaction. So you will exclude it like this. All right. Okay. So the last question, we have 8 minutes. So this is a 45-year-old patient with uh, refractory pruritus, not responding to anti-allergics, topical creams, and steroids. Anyone? The last case? Can you hear me?
Yes, yes, we are hearing you.
Yes. So take the last case and then we will wind up. This patient has refractory pruritus. He is 45-year-old and his pruritus is not responding to any medication. He has applied a lot of steroids, cream, anti-allergics, um, a lot of medication he has used, but no relief. Any comments on these cells?
So we can see population of mononuclear cells, um, small to medium size, with increased NC ratio, and
Mm-hmm.
some of them has clefted nucleus.
Okay. So the nucleus is mature or immature?
Looking like mature. Nucleoli is also, but there is nucleoli as well. 1 to 2 nucleoli.
I think this one might look like the hand mirror appearance.
Okay. So this one has a hand mirror appearance. What about the nucleus?
The nucleus is slightly open chromatin with prominent nucleolus in that one.
Okay.
There's also nucleolus in this one.
I might be wrong, but they seem mature to me.
Let me show you a few more. What about this cell?
It's a large size cell with irregular nuclear contour, low NC ratio,
Mm-hmm.
and the nuclear chromatin is condensed.
Right. So the history and these cells. Any thoughts?
Some T lymphoproliferative disorder.
What about this cell?
Again, it's a large size cell. Actually, even in the chromatin, there are area of euchromatin and heterochromatin. There are some lighter and some darker areas. Actually, they are not the nuclei. They are the nuclear pattern of these atypical lymphoid cells. I might be wrong, but I think it's.
Do you think these nucleus are cerebriform?
I want to make them, but I'm not convinced.
The patient history and these nucleus shapes, because their nucleus is different than other cells that we have seen so far. Small one.
This one is looking like a cerebriform, lower one.
To me, both looks like a cerebriform. And this one as well.
Mm.
They have a lot of folds in the nucleus. The top one. See this fold and this one fold and this fold. So these are Sézary cells. And what about this one?
Dr. Amar, what I have seen, I had seen a case of cerebriform of T cell lymphoma. They were some like a fetus shaped nucleus. I mean, they have prominent cleaving in the nucleus. But you are right, 1 to 2 cell. I have a suspicion. I had suspicious when I was seeing, but
So
I was not informed.
they are called cerebriform. So cerebriform has a lot of lines in the nucleus. So these cells have a lot of lines in the nucleus as well. And this one is just like a brain shape with a brain stem as well. So this one has a lot of cerebriform lines, the top one. So these are the Sézary syndrome cells, which will come in the exam, and they will ask you about the flow cytometry. This is a typical Sézary cell with cleaves, with lines in the nucleus, mature cell, and folded just like cerebrum of the brain. So refractory pruritus plus these cells make a diagnosis of Sézary syndrome.
Okay.
Right.
So how
Do
we
you
are
know?
going to report it?
Okay. So the blood film shows multiple atypical lymphocytes with mature nucleus having a lot of curves in the form of cerebrum. The red cells and platelet count look normal. The blood film is consistent with most likely Sézary syndrome, but we need to confirm this on flow cytometry. So if this patient has any lymphadenopathy, which is less likely, uh, you can send biopsy from the lymph node, but usually it is the skin biopsy that tell us whether there is Sézary syndrome infiltration or not.
So do we get
Then,
some? Mhm. Go on.
then the
I
flow,
think
flow cytometry. Yes.
very rare cases in which there is infiltration of bone marrow, as far as literature is saying.
Yes, the Sézary syndrome, when it infiltrates different organs, then it becomes Sézary syndrome. That's why this is the name. Otherwise, I think if it only involves the skin, it is called mycosis fungoides.
Cutaneous
If
T cell
I'm
lymphoma.
if I'm not wrong, it is a peripheral T cell lymphoma. But when it involves the other organs, then it becomes syndrome.
Dr. Amir, if can we write in our report that our findings are consistent with TNHL, will it give us some point or it will deduct our points?
How can you say this is a TNHL when you don't have the flow cytometry with you?
Because it was because of the history, because of the presence of pruritus, it came to my mind that it's some T lymphoproliferative disorder. I was trying to make it it's Sézary, but I was not convinced. That was I didn't say, but still it was in my mind. It could be Sézary. It's related to some T lineage. So in
Yes, but
exam you were not sure. So what would be your safe reporting in that case, or you just go for your intuition?
so I would not say it is a B cell lymphoma or T cell lymphoma
Mm-hmm.
because I need a flow markers for that to surely say that this is B cell or T cell. I would say this is, if I'm not sure, that this is a non-Hodgkin lymphoma, but I need further investigation to confirm the lineage and the type of lymphoma. But if they have given you a refractory pruritus, so I think their expectation will be more that you have seen a lot of such cases in your practice,
Mm-hmm.
and you will be able to narrow your diagnosis to peripheral T cell lymphoma, NOS, or peripheral T cell lymphoma like Sézary syndrome, because these are the one which involve the skin.
Mm-hmm. Okay.
I'm not sure about anaplastic T cell lymphoma, whether it involves the skin or not. Uh, or the other one which involves the skin is BPCDN. BPCDN is usually diagnosed on skin biopsy, but it is very very rare to give you presentation like this because we have seen the blood films of the BPCDN and they are completely empty. They don't have any significant cell in the peripheral blood film. But these cells are quite significant, mature, cerebriform, with pruritus, so you can narrow your diagnosis. And also, you cannot give any definite diagnosis on the blood film, and this is not an expectation from you. Even PhD consultant professors cannot make diagnosis on blood film. They always need supportive investigations to confirm any diagnosis. We have recently a blood film, um, which we were thinking as a registrar that this can be NPM1 AML because the cells were just looking like the NPM1. Our consultant says that no, this looks like CLL. The patient has pancytopenia. But when the report came from the HMDS, it was a DLBCL. So you cannot be sure on the blood film. You cannot say that this is the diagnosis. You have to request for supportive investigation.
So that's why I'm saying, can we go straight to Sézary just by looking?
That's why we say most likely consistent with. I'm not
Mm-hmm.
saying this is consistent with Sézary. I'm saying most likely consistent with Sézary syndrome, but I need further investigation to confirm this, which is flow cytometry.
Okay. And how far they go for this in Viva for this case?
This case does not come in the Viva. It is a short case always. It has appeared multiple times where they ask regarding report the blood film, what is the expected flow cytometry, and what is the management of Sézary syndrome.
So what is the management?
So the Sézary syndrome management is quite wide. Um, you give the immunosuppressive therapy, steroid. If refractory, then we use photopheresis of these for these patients. Um, and if not responding to photopheresis, then there are some special chemotherapy drugs. And, I forget the name, but there is one drug for that, including interferon as well, which is not licensed here. It is FDA approved, but on compassionate basis we use it here. Starting from B, but I forget the name.
Okay. Thank you.
Okay, so that's it for today, and see you next week.
Sorry, one more thing. There is no any specific immunomarker for it, but there are 2, 3, there are 7 and 8 negative and 25 negative, but there is no specific immunomarker which is present in Sézary. It's like that?
Yes, there is no specific marker for them. They should be having T cell markers and CD8 negative,
Okay. Thank you.
and the morphology will help you in diagnosis it. Okay, then. See you next week. Thank you.
Thank you very much. Thank you.
Thank you.